less than 2 hours, but it's fine. Okay, so yeah, I'll start talking. You want to do that, and I'll start talking. Okay, this is maybe a little bit bigger group, I think. I don't know, but it'll be good. It'll be you'll enjoy it. Hopefully, we'll do our best. My voice is kind of going out a little bit from just basically continuous talking now for 4 hours, but that's that's okay. So we're going to talk today about transport, but mostly trauma stabilization, trauma assessment, and treatment, initial stabilization and treatment of the trauma patient. You know, I think you all usually have such excellent English, and I've been doing this for many years, so I think I can speak in a nice rate, not too fast, use correct English that's understandable and easy. Hopefully I can make the explanation good. If there's any question, you can just do this and we can talk in English, or Davide can jump in with Italian. He's going to speak a lot of Italian too, because the fact is, I'm trained in trauma resuscitation, but my career now doesn't involve resuscitation of the trauma patient, because my career is in pediatric ICU. And in the United States, it's a little different than here. The doctor in the case of Davide goes to the patient so he does this resuscitation. In the US, I'm just receiving the patient. So after this is really done. So so maybe you can say you're lucky, because between the two of us, it goes from the side of the road all the way to the ICU. So he has a very unique expertise that I don't have. So we work. It's true. No, it's true. So we kind of do this together. Also, he's trained in ATLS, Advanced Trauma Life Support, and PHTLS, Pre-Hospital Trauma Life Support. This is something I have done some years ago, but I'm not current in that. However, I can still present to you the latest and the nice approach to the evaluation and initial treatment of the trauma patient. So, you know, children are not little adults. What exactly does that mean? Let's talk about a few differences in anatomy and physiology that are particularly important for trauma. So, for example, this is a big one. The baby and the small child have a large head, you know that, compared to the body. And as we grow, we become tall, and basically our head stays the same. And so my head is small compared to my body. What does that mean for the baby? In the same accident, the child is more likely to have a head injury than an adult. For these reasons, the head is larger. There's just, it's easier to get bonked, to get injured. Also, remember, the neck and the strength of the neck, and especially in the small child, is not good. You know, of course, infant, you know, can't even hold up their neck. You know, they have to strengthen their neck. So so you have to be aware that this is a risk. Also, the skull, of course, is softer. It doesn't protect the brain as much as the adult skull. The fontanelle is open, so you can injure the brain very easily. However, on the good side, if the baby, the small child, has increased pressure, the fontanelle can expand, that accommodates the pressure, and the skull can expand. So that's something to consider. Shorter trachea, the trachea is more anterior, shorter larynx, and the shape of the larynx is different. Your larynx is more like a cylinder or a tube. The baby's is more like a cone. So it's wider here, and the larynx of the child comes down to like a cone. And then here's the vocal cords. So what does that mean when you're trying to put in a tube? Maybe you've had a presentation from Monica, for example, and you know, she's talking all about this. So that's a consideration. What does it also mean? A small airway it can be obstructed quite easily. If my larynx is this big and I have a tooth that got knocked out, or I have bleeding or mucus that plugs up this much, I can still breathe. But if the baby's airway is this big, the same obstruction is potentially deadly. So airway obstruction, more common, more difficult to deal with. Then last is the chest wall. It's very compliant. So, you know, we adults have a rigid chest. So a lot of our, you know, tidal volume is generated by our diaphragm, but also by, you know, the expansion and contraction of the intercostal muscles. But the baby has a very soft chest. So babies really just breathe with their diaphragm. If you look at a baby breathe, the baby's sitting here like this, but it's mostly his diaphragm that's moving. So these are significant differences. Finally, the belly for a baby or a child is relatively bigger. And what that means is two important organs, the liver and the spleen, are sticking right out. So the same blow to the abdomen for me, the ribs protect my liver, I'm probably okay. The same blow to the baby, he has a liver laceration or a splenic laceration. I mean, if you've ever tried to feel the spleen of an adult, it's hard to feel. I'm not even sure you can feel it. But a baby's spleen is pretty big and it's sticking out there. So like spleen injuries are more common in children, and liver lacerations. How about physiology? There are definitely some physiological differences as well. So children have a higher metabolic rate. So children are consuming more oxygen compared to an adult, which means that, remember, for shock is where your consumption of oxygen is higher than the delivery of oxygen, right? And so then if that happens, you're in shock. So children are closer to being in shock at all times compared to adults. And the response to shock for children is impaired. It's less than adults. One of the main reasons being your heart rate. One of the ways that an adult very quickly can increase their cardiac output is increasing your heart rate. So if my heart rate is 60 right now, I can easily go to 120, boom, 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 and I have mathematically doubled my cardiac output because my heart rate went from 60 to 120. But an infant has a heart rate of 140 maybe. Can the baby go up to 280? No. So the baby cannot increase their cardiac output by rate as much as the adult. The baby is already closer to maximum rate. Adults could even maybe triple. Like you guys are young. You can triple your heart rate. You can go from 80 to 160 to 180. It's pretty crazy, 200 even. So if you need to. Remember 220 minus your age in years. That's your max heart rate. I don't know if you knew that. So you guys are 30, whatever you are, you're close to that. So your max heart rate is 190. I'm 55. So you can see, you guys already, I'm at more risk than you. So you want to show them some of these nice things? Yeah. Yeah, I should show them that. Yeah. So these are some nice graphs that demonstrate this. Yeah. Yeah, blood pressure is not shock. That we don't define it that. It's not, blood pressure does not define shock. It defines different types of shock, compensated or uncompensated. I understand. I hear what you're saying. And this is why this is important also for all of resuscitation, all of pediatrics, not just trauma. So trauma, these concepts apply to patients, for example, with hypovolemic shock from dehydration or vomiting. So the child can have maintain the blood pressure and then at the last minute crash, basically fall off, and that's what that chart shows. I think an important point we've been bringing up on these lectures today is also the concept of blood volume and blood loss. So if you've been in a NICU, if you've ever worked in a newborn neonatal ICU, where the baby weighs only 500 grams or 600 grams, they keep track of the loss of blood down to the milliliter, half milliliter, because the baby has such small volume. But sometimes we forget that that's true as you grow. So adult male has 5 liters. Let's say I have 5 liters of volume. And if I'm in shock, 10%, if I lose 10% of my blood volume, I'm in shock. If I lose 20%, I'm in very deep shock. So 10% would be a half liter. So this is a half liter bottle. So if I lose this much, a whole bottle of this of blood from an injury, I'm in shock. That's why hemorrhage control is so important in trauma. But let's think about a 1 kilogram baby, a child who weighs 1 year weighs 10 kilos. 1 year old weighs 10 kilos. And the volume is about 70 milliliters per kilo, something like that. And so that patient's entire blood volume is 700 milliliters. And if that patient loses 10%, he's in shock. So that's only 70 milliliters. So, that's only this much. This is 500. That's about this much blood. So that's not that much, really. Even a big scalp injury, you can bleed that much. So with what appears to be not a large amount of blood volume for a child is very important. And that can create a shock situation. So when you see, if you're working in an emergency department and you see, certainly if you see a baby like this and the clothes are all bloody, that baby's probably in shock because that's probably 20 milliliters of blood. And this baby weighs 6 kilograms. He has 180, 370, 210 milliliters of blood volume. Anyway, he's 10% in shock. Yeah. So I think, we've done this now. This is the third time giving this lecture. And I think maybe it's important that we say for the discussion today, when we talk about shock, we're really talking about hemorrhagic shock, loss of blood volume. Now, sometimes trauma patients also have cardiogenic shock. Maybe they have a myocardial contusion, right? A bruise on their heart, so the heart isn't beating. Sometimes trauma patients have obstructive shock because they have a tension pneumothorax. So there are other kinds of shock with trauma, but for our discussion, let's think about hemorrhagic shock. Okay, so when we do the assessment, it's similar to a PALS assessment because we have pediatric assessment triangle. This is the initial observation if the patient is sick or not sick, stable or unstable. But then we also do airway, breathing, circulation, and then this is unique for trauma. Disability, which is where we look to see if there's any neurologic thing that we can identify, either from head injury, spinal cord injury, or peripheral nerve injury. And then finally, we do exposure, which reminds us to remove all the clothes and look at the whole body, not just look, touch, evaluate, palpate, the whole thing top to bottom. So yeah, let's, what we can start it here is, well, pediatric assessment triangle, just like PALS. And when you're walking up, we look at the appearance. It's important. Is the patient sleepy, not looking around? Are they alert? Can they look at us? How's their breathing? Is it labored? In other words, it's not normal. And how's their color? Is it blue? That's bad. Is it white? That's probably also bad. Or is it pink? So you guys, you know this, and we use the same in trauma evaluation. But then pretty quickly, we go to airway. So the main idea for airway is we want to anticipate problems before they happen. And so that's going to go from everything from your equipment to the evaluation. But maybe we can do the evaluation here of the airway.
Perché ricordate che le discontinuità è una sola cosa che dovete immaginare, e lo trovate qua, guardate. È una cosa fondamentale.
Obviously.
Allora qual è? Quando io mi accorgo che sono delle emorragie, la prima cosa da fare è andare a chiudere immediatamente l'emorragia, e se non ce la faccio, lo vedremo. Fatto questo, io poi mi dedico a ma io ho dei perché questo succede dell'idea. Non lo lascio per tempo, non lo spiego. Nella valutazione primaria, poi c'è un quindi qual è il metodo che devo fare?
So it's important that we start at the top, we do airway, then breathing, then circulation, as you're saying, because each of those you have to address in order, because if the airway is bad, the patient's going to die from that before you get to breathing. If breathing's bad, the patient's going to die from that before you get to circulation, and always finding hemorrhage and stopping it. Because if there's ongoing hemorrhage somewhere and you don't stop that, then all of the rest is going to be, for no use. Yeah, yeah. Scene is safe. Here we come.
Ok, bambino, ci sono emorragie evidenti?
No,
No, non sa.
no, not bleeding anywhere.
Ok.
So he has nice control of the air of the cervical spine, and now I can look.
Cervical spine subito in A, perché? Perché ricordate che qua ci sono i centri del respiro, ok? Tendono neusti che prendono tassi, ok? Le lesioni alte, oltre a dare shock molte volte, oltre a shock cardiografico, perché shock emorragico dovuto al trauma, dà anche un problema ventilatorio, qui si scoppa la respirazione. Quindi la cosa fondamentale, cervical spine, ok? Controllo le vie aeree.
So airway looks good to me. It's open. I can't see any foreign body there. No tooth, no blood right now.
Ok, eventualmente.
Okay. And now he does a little jaw thrust. Airway is open. I can hear it. Notice he's not doing this. Cervical spine is perfect, but he's moving the jaw forward. I hear air going in and out without obstruction. So that means the airway is patent. It's open.
Quando è che si fa la giornata? Quando è incosciente, per cui la lingua, soprattutto nel bambino, enorme, si adagia dietro tutte le vie. Basta fare una subluxazione della mandibola, la mandibola si tira dietro la base della lingua che si allontana dalle vie aeree, e lo faccio come dice lui, mantenendo l'asse della colonna.
Just to maintain everything in a nice line here. And what you want me to do? Take a look at the trachea.
Controlla il collo. Non lo fate ora, lo farete più. Controlla perché.
Yep.
It's okay.
Yep, it's okay.
Ok, controlla i giugulari.
They look good. They're flat, maybe distended, but no, these are flat.
Ok, controlla se c'è sistema sottocutaneo o, come dice lui, masse pulsanti che spingono la trachea.
Yep. So how is the trachea? Is it, is it to push to the side or is it in the center? Of course, should be in the center. And then feeling, do I feel any air in the neck? Any, what we call crepitus? Do I feel any crunchy air? I don't.
Okay.
Yeah. Yeah. And then we can go ahead and get the C collar on. And this is an adjustable collar, which is nice, but there we go. So that goes down like that. And he has nice control. I can feel under here, feels good under the neck. Gently come through with the collar.
Okay, go. Stop.
Stop right there.
Okay.
He tells me, now I come over with this. And this is important. You see, we're having communication together. I'm moving, he's talking to me. He sees things I don't see. So we really have to have an open communication. And the important thing is maintaining control of the cervical spine. Sometimes people are trying to do something and they think they're doing something good. Maybe it's like, oh, I want to start an IV and I start doing this. And he'll no, stop. Don't have this. So anyway, so now we have this C-spine in place and that's the airway. Oh, then we apply oxygen to the trauma patient. Because remember, anyone who's in shock, you want to make sure that they are maximally saturated. They have the best saturation they can get. Because remember, if you have less delivery of blood to your tissues, you want to make sure the hemoglobin is fully saturated, 100%.
A pochi globuli rossi, quelli che ci sono deve essere tutti salvi.
Yeah. Okay.
Okay. A is okay.
Yeah. So A checks out okay. And now we see this. We're ready. This basically what we've demonstrated for you is this. These are the assessments. The airway is patent. How is the level of consciousness? Is the patient, remember if the patient is sleepy and kind of out of it, not awake, that's when the tongue goes back. So you can have patent airway, which is no sounds. You can have partially obstructed. Okay, not so good. Maybe a secretion, maybe too sleepy, big tongue. Maybe the tongue is cut in half. Maybe there's a tooth in the airway. Anything's possible. Maybe there's sometimes the patient is eating something when they have a trauma. Anything can happen. And then you have full obstruction, which is, or nearly full. Or if you ever see somebody do this, and they move the chest but make no sound, that's obstructed airway. And so we're looking also for things like injury, of course, if there's a specific injury, and that's when we were palpating and looking. If someone has a big jaw injury, putting a breathing tube in is, it's still possible, but it's going to be different. What if this is if there's bleeding or if it's crushed? So it's all important. Stridor, cyanosis. And the interventions you also saw us do: jaw thrust, chin lift, cervical spine immobilization, yes. Oxygen, yes, by mask. If the GCS, Glasgow Coma Scale, is low, we intubate. Sometimes we, depending on where you are, if you're in the ICU, we can wait a little bit on that. It's not a hard rule, but for trauma assessment, it is a pretty firm rule, because it just means if you're this much impaired, you have a high risk of losing your airway. And then we might intubate if the oxygen is low or the carbon dioxide is high. That seems obvious because that's respiratory failure. These things are later and more advanced. If the ear, nose, and throat needs to come, or if you need to do a rapid sequence intubation, a special kind of intubation. But we're not really going into that so much today. Any questions about airway? Okay, now we come to breathing. And so what we assess with breathing is the rate. We look at, we go top to bottom of the way you assess people. First is observing.
All parts.
Oh yeah, do you
All parts.
you do your thing. I like it. You take OPOX. Observe.
Devo guardare intanto se pensa e poi come deve avere questo e cosa mi può dire
Sometimes you have seesaw respiration when you, if you have a flail chest, if you have a broken rib.
È importante vedere se c'è una postale, perché rompere una cosa di un video è difficile, rompere due o tre di essere. E se sotto che è riuscita a rompere queste le cose che sono delle elastiche,
So that's, you can see by the discussion, observing is very important. It might be the most important. But we go down the list, then we do palpation. Feeling everything, feeling for broken bones, feeling for air under the skin. Feeling, yeah, emphysema, subcutaneous emphysema. We call it crepitus, is that crackling sound. So that's OP. Next, so after percussion, then we have auscultation.
Ok, io ascolto. E cosa ascolto? Sì, no, c'è, non c'è. No, è bimodale, non sono altre cose.
Yeah.
Apice, apice, si mette. Base, base. Impero basale, impero basale. Basta sapere sì, no, perché se da un lato è, da un lato no, ed è lo stesso lato in cui ho visto che c'è una simmetria, c'è anche l'emfisema. Questo paziente ha uno neurologico, sì, perché sono come una accorgete, unicamente. Perché muore un paziente? Per shock? Quindi se c'è una composizione dinamica importante, avete tempo per il qualcuno dei gruppi di me anche però non sa che questa è temporale, ma per l'emologico se uno sportivo è uno ha fecale. D'altronde, come dice Marco, se c'è il primo torace esce fuori, lo facciamo e basta. Se non c'è, l'abbiamo fatto noi, non è niente, abbiamo poi dato.
And so really it's that yes and no. I mean, it's not, you're not listening for small things. You're listening for big things. Is air going in or out? Things like that.
Poi c'è palco, ascolto, c'è anche per fuoco, ma la percezione lo potete fare dentro, fuori,
And that might be for more like a big hemothorax. I mean, it's hard to get a lot with this, but if this is like, sounds hollow and this sounds like, dud, 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 maybe there's blood there. Or maybe there's a mucus plug, you know, something like that.
Poi c'è conto, non faccio, conto la produzione respiratoria. Perché è importante? Perché tu hai la simmetria sopra, sotto, destra, sinistra. Il paziente ha un controllo. Lavorano sotto. Quando io ho una torace continua in emergenza, siccome è l'unico modo che riesco a pensare è che ma se non riesci a ventilare le 4 ore, non pensare perché fa. Non sentirò mai la risposta. Quindi ho la frequenza esatta. Quanto la frequenza, come la conto, molto quanti altri fare. Ora non mi interessa sapere se il gruppo pure 7, 8, 9, 10, cambia poco. Io devo capire se ha una aritmia, una pratica. Sono 2 estremi dove non devo andare. E se ha queste situazioni e non sento bene, cosa devo fare? Lo devo vedere prima. Ricordate che però un po' che sempre fanno così. Ricordate che aumentiamo la pressione circolare. E la causa più frequente non deve per questo è il calcio. Quindi tutte le volte, che ventiamo il bambino, una delle cause di peggioramento di morte di bambino è saturimetro.
Oh yeah, saturation.
Saturimetro è importante se lo mettiamo. Il bambino sciupato e allora perché lo devo mettere? Perché non lo spiego? Perché devo cominciare a misurare per le fasi successive, perché poi io lavoro e quindi vedo come va, se mi peggiora mi peggiora. È la stessa cosa che io faccio i prelievi per strada, la stessa cosa che io faccio l'ecografia per strada, metto sempre a tempo zero, l'ecometria a tempo zero. Ricordate che il trauma è una evoluzione, io è una video clip dove tutti i fotogrammi fate voi quindi c'è uno stato iniziale, quando lo controllo, come sta in modo che poi non lo posso rivedere e vedo come muove il paziente. Questo è fondamentale, la prima valutazione continua permette di vedere come sta andando il paziente, evitare anche quello che si chiama errore di fissazione. E vedo che non mi sta andando come mi deve andare. Non mi viene quindi giocare che cosa sta andando mi dico cosa non sta andando. Può essere che la linea di anni è sbagliata, mi devo orientare su questa cosa. Ecco perché è importante. Ecco perché è importante registrare sempre di più. Perché mi serve un attore per vedere come sta andando. Se non parte, la più si fa ok.
So we need to have some, after we've done this assessment, we need to consider some interventions that may be important. And these are two that that are things you should know to do, especially this top one. And I heard it say tension pneumothorax. Remember, the tension pneumothorax is both a breathing and circulation problem. That's why it's so critical to be able to recognize it and treat it immediately. The classic teaching that you get in PALS is second intercostal space, and put the needle in, push it in over the top of the rib, you know, and then listen for the psh when you pop the balloon. I think sometimes this is hard in babies. I think it's hard to feel that small little area. It's kind of under the clavicle. In some people, there's, you know, muscle or some skin or fat. So for me, I like to come over here. Fourth intercostal, good. Not up here, okay, good. So it's news to me. That's why, I mean, it's good to get this latest for the, when you do PALS, like when you do the games or whatever, a lot of people are going in the second intercostal space. But for trauma, ATLS, we like this, and I'm glad to hear it because it's my favorite place too. Why? It's very easy to see the landmark. This is the nipple. Everyone knows how to see it. This is the mid axilla line. Come right over. That's going to be the fourth intercostal space. Yeah. You can just feel it more easily. The other thing is sometimes if you can't feel the rib so well, you gently put the needle in and sort of feel for the bone. You'll clear when you hit the bone. And then if this is the rib, go, you know, lift over the top. Yeah. Over the top. You can kind of.
Quindi vado sulla costa inferiore, inferiore perché se vado su quella superiore devo sentire quello che perché scivolare.
Yeah. I kind of say like walking it over the top, walk the needle over the top of the rib, like move it up and then it goes over the top and in. Now, if you have a tension pneumothorax, you should hear this sort of, sometimes it's a spurt of air or a little something like that. But sometimes you'll be wrong and there's not a tension pneumothorax and there's no air that comes out. That's okay. We like to say, if clinically it looks like a tension pneumothorax, you should not wait for the chest x-ray, because the chest x-ray, you know, by the time the x-ray comes, it may be too late. We like to show this. This is a very, very extreme tension pneumothorax. Trachea is way over here. Flat diaphragm, big distended hemithorax. The lung is actually herniating all the way over here. This is all lung coming out here. So this is a real emergency. Hopefully you've already put the needle in before we get this x-ray. So, okay, here's another interesting one. Just nice to at least look at this. Maybe you can see, say what you see here. What findings do you see here? Anything, should be able to see a few things. So an important point I think to make here is there is a tube to decompress here, and already this, but still the stomach is large. Without decompression, sometimes you'll see the stomach be this big. It'll be huge. And then there's a high risk of throwing up. It's also difficult to ventilate someone whose stomach is this big. So if you're going to have a prolonged bag ventilation, you should have a tube in. Look at all this air here, and it still has a pneumothorax sitting up here, and maybe under tension. This heart is starting to get pushed over, and the trachea is a little pushed over. So, tension pneumothorax develops with time. The more you bag, the tighter it gets. So this is a good X-ray, I think, to see too. Okay, circulation is the next thing we do. So the general idea is we want to make sure we get vascular access quickly. Again, let's assume the patient has hemorrhagic shock. So the interosseous is really something that you want to go to quickly. Someone was asking me, well, does it have to be interosseous right away? I guess if someone can have an IV immediately, but usually when the patient has hemorrhagic shock, it's very hard to get the IV. And by the way, remember, we need a big IV that we can give lots of blood fast.
E se noi la facciamo, la prima via qual è? Hai grossi due. Il grossi ha fatto
distal radius, and there are a lot of places you can do distal radius too, but this is your best place to go. Yeah, and you've practiced this maybe, or you've done in simulation some of this interosseous. Yeah. We haven't really talked too much about the details of that. I will just say that, do you have the little, this is drill. It's a good one for a little bit older kids whose bones are calcified. I find when you use the drill on a very small child, it can get loose. It can, what we call strip. It's like too much. Yeah. So what in an adult, you can just drill it right in and it's done. But a baby, you can strip. Too much torque. There's too much force. So I like to do, and you have the needle right here. The smaller the baby, if it's really a small baby, what I like to do is just, you take the tip off here, and you can just use this. You don't have to use this in the drill, and you just can use your hand and just use, you have much more sensitivity when you put it in yourself, I think. Because it's kind of with a baby, with an infant, or even kids less than about 3 years old, it's a sensitive procedure. Push down, and you'll feel a little drop there. Now, once you have it in, you have to keep it, but there's a lot of practical issues about this. But get good access. You have to get good access, and because you want to be able to give blood products. Again, let's assume hemorrhagic shock. We're going to be giving blood, whole, packed red blood cells or other products. Maybe you're giving crystalloid if that's all you have. Early in the administration of someone with circulatory shock, we're giving tranexamic acid. TXA is what we call it in the US, TXA. It's an anti-fibrinolytic. Remember, the body breaks down fibrin, and TXA goes against the breakdown of fibrin. So it helps your clot stay strong.
principale che parte allora il transito dopo questo tempo questi anche il a stabilizzare il quadro. E a proposito di questo è importante il controllo dell'inizio. Quando il possibilità di essere la decisione deve essere controllata, che è un tanto di persone che non America da aumento della pressione allora, tante persone per morire io ho cercato di trovare perché devo scegliere quello che mi serve per fondere il cervello e lo posso e quindi so che tante persone per questo mi permette di mantenere altrimenti parte questo quadro che si è formato di fatto fare seconda metà però queste cose e mantenere al minimo della pressione quindi la pressione
ok.
Ecco, no, lascio per il sangue, attenzione, lascio per il sangue dove dovete fare lentamente, perché siccome è fortemente questo paziente è puntare e non si vede paziente che soprattutto il bambino che in Italia è sempre solo. Quindi il trame si fa distribuito nettamente ovvero più
Okay, yeah, yes. Okay, we're just gonna do one quick thing that's a little bit fun, because right now it's 8 o'clock in the morning in California, and my son is going to school. He's 11, and he wonders what is dad doing? So I'm just going to, you guys are all in the background. Okay, everybody say hi. Okay. So now he sees, what are you doing? What are you doing? So I said, I'm, I have 1 hour more. I've been talking for 5 hours. Thank God for Davide. It's really hard to talk continuously for all this time. So anyway, thank you. He'll be excited to see this. Okay, so the tranexamic acid early and potentially some other things, more modern or newer ideas now is Novo 7, which is a concentrate factor 7 that promotes clotting. So, but let's just go a little bit deeper on this. We've talked about the assessment of circulation for trauma is really the same as for PALS. We're looking at things like heart rate, but most important, capillary refill and peripheral pulses. We've really discussed this a lot. These are good. It's good for you to practice this with every little pediatric patient you have. When you see a kid, just put your finger on his top of his foot. It's great if you can learn how to feel this distal pulse quickly, because it's important. And so feeling the difference between the central pulse and the peripheral pulse is also important. There's really a continuum from normal to 15 minutes, 50. Oh, okay, cool. So even less time than we thought, because we thought we were going to 10 after, but instead we're going to go till 5 minutes until 5, right? Is that fine? 50 more, 50 more, 50. Okay, we can do it. We can make it work. Okay, super. So anyway, it's actually quite sensitive way to assess shock by looking at capillary refill, peripheral pulse, and central pulse. And I'll just tell you the whole range. Right now, My capillary refill is 1 second. My central pulse is strong, and my peripheral pulse is the same strength.
Ha parlato di persone che fanno. No, e intanto ho detto che lo potete vedere. Allora, prima di tutto cosa che detto? Colorito. È marcato. Poi potete poi potete e il PIL è corso del tempo, potete vedere adesso. Perché il corso del tempo? Non lo sentite nessun posto, e poi vi dice di confrontarlo con centrale. Perché vi dice di confrontarlo con centrale? Che cosa? Intanto per vedere la frequenza e poi per capire se è un problema per il medico centrale. E se io sento questi ho deboli centrali, ma se io sento deboli posti e forti centrali, oppure sento forti centrali deboli dov'è il problema? Lesione vascolare che probabilmente non è questo è un problema vascolare. E se non sento differente troppo per sotto, per destra e sinistra, cosa mi scordo?
So as you develop more shock, the capillary refill gets long, of course, and the distal pulse starts becoming less. And then ultimately the central pulse becomes less. When you have no central pulse, then you need CPR. So as people get worse in shock, you will be able to say, okay, the distal pulse is, I can barely feel it, and this feels normal. That's an emergency. That patient is in shock. They need resuscitation. So I think it's an important point to make. Remember also, the brain gives you an indication of shock. If you're sleepy, that could be many reasons. You could have a head injury, you could have cerebral edema, you could have intoxication from a drug or alcohol or something, but it can also be you're just in shock. And when someone is in shock and they're kind of sleepy, it's very, very satisfying if you give them some blood and they literally wake up. You feel like kind of, I don't know, magic or like God or something, because you can wake people up basically from almost dead. So it's really, really incredibly satisfying if you identify shock and treat it aggressively. Those two things come together. When you've identified shock, you have to treat it aggressively. And so what we see with that, we're going to make the point here. Get control of the bleeding, have good IV access, give the bolus of 20 per kilo with blood if you have blood. I put this here because very often there's not blood immediately available. It depends though. If you're in a big trauma center, you may have blood right there. But if you're at another place, you may first use
sangue. Quando l'emorragia, io metto sangue, io metto acqua, non posso proprio grossi, perderà lo stesso ma cos'è che ci interessa? Perché la pressione la prima scelta se non abbiamo il sangue completamente.
If you're bleeding, give blood. Is that what you're saying? Yeah. Yeah. Only give saline if you don't have blood right now available. But you just need some volume to keep the patient from having cardiac arrest. But of course, if I give you normal saline or lactated ringers, LR, you can't carry oxygen in that. So blood is important. As you give mass transfusion, as you need more than 20 milliliters per kilogram, and you do 40 or 60 or 100 milliliters per kilogram, remember, the red blood cells are one part of the blood, but we also need coagulation factor, which is usually in FFP, fresh frozen plasma, and you need also platelets. Because if I'm not just bleeding out red blood cells, I'm bleeding all of it out. So some places in the US, maybe not so much here, use whole blood, fresh whole blood. It's a very nice thing to give to patients, but it's a practical issue. It's hard to store. It doesn't stay fresh for very long. And so more common still, even in the United States in big centers, is to use three products: packed red blood cells, fresh frozen plasma, and platelets. And the ratio of 1 to 1 to 1. So equal parts of the, well, relatively equal parts, 10 milliliters per kilogram of red cells, and maybe the same of platelets and FFP, fresh frozen plasma. We used to, it's interesting, we never really realized that. When I was your age, we would give people lots of packed red blood cells, and then they would start bleeding. And it's like, what's going on? They developed what's called a dilutional coagulopathy. I gave you a bunch of packed red blood cells. Maybe I gave you some saline, but now your volume is expanded, but you don't have enough platelets and FFP. This research is done in the US military to understand, what is the best ratio? And people have looked at different ratios, but that's what we do. Dove io dico il sangue a pezzi, dico grossi, dico pasta. Io continuo a dare sangue un sangue che questo lo fa separatamente dopo i rossi e stile plasma. Dove quando io mi tutti devono essere calmi perché il paziente è un dato da incontrare di non è io così quindi anche questo ma se lui fa che non uguale a se no perché ha la stessa e quindi come parlare con questa cosa dato dalla somma delle relazioni se anziché 9 non c'è stato 4 la temperatura ricordate che sulla tria
necrosi, ipotermia, coagulazione. Non a caso, il primo ancora collegato. I famosi pazienti che morivano seconda, terza, quarta, quinta, respiratorio.
So this just, oh yeah, go ahead.
Quando sembrate sempre a poere, dice vedi come va. Chiaramente più ne fai di queste qua, più vuol dire che questo tempo importante. Fino a quando l'emorragia non è bloccata, tu non ce la fai, ma considera che può fare differenza. Ma se tu non gli studi quel punto, e non è detto che devi fare la restrizione epatica misurata o la ricostruzione, no, devi fare un contro il sistema. È una chirurgia di damage control. Quando è stabilizzato il paziente, damage control sul tatuaggio, lo dice in dire quando la prenda umana che stop il serramento, per stop il posso utilizzare perché uno che si utilizza
Seems like good discussion. I'm catching a little bit. It's good. No, I mean, this is, I think you have the idea of the approach to circulation and the treatment. Just to stress again, good IV access, aggressive resuscitation with the appropriate blood product. That means warm. I know you're talking about that, warm blood, et cetera. Resuscitate well. This was just to remind you of the blood pressure normals. Of course, you know, as pediatricians, they vary by age. And you remember the little formula, 2 times the age in years plus 70. So this is nice. And keep in mind, these are minimums. So this is, 5th percentile, 2 standard deviations. So less than this, that's decompensated shock, not just shock, but decompensated shock, hypotensive shock. We've really been talking through this already. So, and you can take picture if you like, but this comes from a website and I will give you the address at the end of the talk. This is from the Royal Children's Hospital at Melbourne, Australia. And I think it's a nice approach, but I'm not going to go through all of it because it's everything we've been talking about, starting with tranexamic acid, using blood. Do you still have shock? Using blood some more, making sure it's warmed, right? And then if you have persistent shock, just going down the list here. Again, FFP, packed red cells, ratio of 1 to 1. So this is everything we've really talked about. The only thing we didn't mention, but maybe you did, keep in mind, once you start giving someone a lot of blood products, very often their calcium is down. Maybe you already mentioned it. I don't understand the Italian totally. But citrate, remember there's citrate in red blood cells in the blood bank. And so your calcium falls. So you need to replace some calcium. And there are some other considerations. Potassium, I know you've been mentioning, especially if you have a small baby in hemorrhagic shock and you're using old blood. Because blood, I think, can live it in the refrigerator for like 30 days or something. Something like that. When you donate blood and they take packed red blood cells, it can sit in the blood bank for a month. But every day, some of those red blood cells are opening up and releasing potassium. So old blood at the end of its life can have as much as 20 milliequivalents of potassium per liter. So if you're going to give, it's a lot of potassium. And I've seen it happen, especially in small babies, that you can create hyperkalemia if you're resuscitating. resuscitating a baby. So you just have to be aware. There's certain things you just have to keep special track of as a pediatrician. And that's why you're a specialist in children. So sometimes if we're resuscitating a baby, we can call the lab. I mean, not me, but somebody please call the blood bank and say to them, give me the fresh blood. Don't give me the old blood, because the protocol in the blood bank, of course, is just like in your kitchen. This cheese is almost dead. This cheese is fresh. I'm going to eat the old cheese first, right? Or whatever, the old meat. So in the blood bank, they will give you the old blood. It makes sense. So you, as a pediatrician, you may have to say, I'm sorry, today I need the fresh blood because I have a little baby. And remember, a child who's that big, who's 6 kilos, only 250 milliliters is a huge amount of blood, and you will create hyperkalemia. We didn't mention it to the other groups, but it's important. Okay, disability, and we'll keep moving because we do need a half hour probably for this, so for the demonstration. So we'll finish up here in the next few minutes. Disability is focusing on the neurologic part. You do a focused neurologic exam, always being very careful to always looking for a brain injury. And sometimes there's a brain injury and it's not obvious to you. Sometimes the injury is a diffuse injury, what we call a diffuse axonal injury, and a DAI. It has a special look on the MRI. Yeah, it happens frequently. And honestly, the babies look okay. The children look okay initially. Sometimes they're a little bit sleepy. They're not really looking at you. And over the space of an hour, all of a sudden they're out. And then the next 6 hours, they have diffuse cerebral edema and they may die. So you have to always be looking for these things. So your assessment has to be quick and focused. We still like AVPU. It is very helpful, responding to verbal or pain. You can also use, and again, the neurologic assessment includes the whole look. How are the pupils? How do the pupils react? Is he moving his extremities? Remember, sometimes he doesn't move his extremity because his leg is broken or he's in pain, or he has a peripheral nerve injury. And then you're looking for things like decorticate posture. It's bad. Decerebrate, even worse. So you want to be looking at these things. If you see someone with, an abnormal pupil and decorticate, or, that patient is going to very quickly need neurosurgery and need a scan of the head once they're stable. So, and remember also, we do like to say dextrose. Don't ever forget it. It's easy to forget. So D, you can just remember dextrose maybe also. In other words, check the blood sugar. Okay, I already mentioned this assessment, and then these are the things you would do if the patient is not maintaining their airway or they're too sleepy. We put in the endotracheal tube. It's important to not hyperventilate. We're not hyperventilating. You'll do more injury with that. So we aim for a normal PCO2 or end-tidal CO2. Head CAT scan, head CT as soon as possible when stable. We're going to talk about that a little bit. And if you think there's a sign of increased intracranial pressure, we do go ahead and use hypertonic saline, like 3% saline, or maybe mannitol.
faccio un esempio. Io mi mantengo una so anche che se per caso segni di cambiamento di sarà causa di basso, ma quindi devo decidere o in caso devo o paziente perché mi dico che aumentare, creare un usa il manipolo per fare questo, per fare una e per fare questo devo avere un devo passare da 10 e il bambino la vede passare e so che mi permette per l'emergenza controllata che mi permette di arrivare prima che si
This is a pediatric classical coma scale. Just to remind you, it's different. You can always look this up. No need to memorize this, but it's nice to use this. But remember, it's more on observation with a baby than asking the baby questions because he doesn't answer. Here's what you like to try to make sure you find. This is a big epidural hematoma. It looks like a lens, it's a lenticular shape. And this is a bad one. The lateral ventricle is gone. It's been what we say effaced. It's been sort of squeezed, crushed. So it's gone. This lateral ventricle is still here. This one is still here. But these are gone. And this is a big one. This has to be evacuated immediate. This is immediate threat to life because all that pressure, you'll have a herniation of your brain down and you'll be dead. So that's an important one that in this artery, the middle meningeal artery is right there and you can break it. So the last one of E is exposure. All the clothes come off and we need to look top to bottom. Remember when all the clothes are off, especially for smaller children, risk of hypothermia. And so keep them warm, but you have to see every part of the body. And when you don't see it, that's when there's a chance that there's going to be a problem. And I talk to the other groups about cutting the corner. It's an expression in English. When you don't do everything you're supposed to do, you cut the corner. You don't go all the way and take the corner. You take a shortcut. And that's not a good thing to do in trauma evaluation. So if you didn't see the back, then you didn't see the back. You have to log roll. And I've seen, there's famous times someone has a knife in their back or a bullet or something. But I've seen a piece of a metal or plastic deep in the skin there. And it can cause, you could have hemorrhage along your vertebral body. And you have to do it. You have to look. Don't cut the corner. Trauma evaluation is a time for just going 1, 2, 3, A, B, C. So after you've done your primary assessment, which is A, B, C, D, E, we have some x-rays that usually we get. The chest x-ray, essentially always is part of this primary evaluation because it gives us a lot of information. You saw the pneumothorax. we can see evidence of aortic injury sometimes. You can see rib fractures. It's just a good thing. You can see the size of the heart. Sometimes, it's just, come on, let's get a chest x-ray. Pelvic x-ray, potentially very helpful. The focused ultrasound is really becoming the ultimate. I think used a lot here in Italy and used a lot more by younger doctors because you learn it from the beginning. And so that's great, especially looking for fluid in the abdomen. It's pretty sensitive for that. You can see if there's fluid in the abdomen, and you have to assume that's blood. We used to do this thing I put here called DPL. You can read about it if you like reading about history, medical history, but this is what we used to do. Diagnostic peritoneal lavage. We would just put a needle right below the belly button, the umbilical cord, and inject saline into the belly. And then literally we would move the patient around and wash that saline and then suck out the saline and look, is it blood? Okay, that's what you get. Pretty crazy, huh? But I mean, DPL, it wasn't that long ago. I'm not that old, but that's what we would do sometimes, DPL. And then abdominal CAT scan, of course, CT scan of the abdomen is very sensitive. So, and cervical spine, all I can say is there can be injuries to the patient's cervical spine that we don't see. So we do get standard lateral AP and open mouth if we can. But very often for smaller kids, we have to go for MRI or CT of the neck to look at the ligaments. That will depend on your institution, where you're working. I mean, here you probably go for MRI if the child is young and you can't, So secondary survey, now you've done the primary survey, secondary survey. Once again, it seems kind of maybe boring, but we start again at the top. And this time, every single thing is looked at and touched and listened to. And you redo the airway, and then you do the whole exam. And the things you're looking for are things like this. I mean, but this is basically just everything. Chest, inspect, palpate, listen, abdomen, inspect, palpate. Is it tender? This is an important one we didn't mention in the last group. Maybe you did, but we should mention the old days we used to take the pelvis and push down to see if it's unstable. Now we're much more sensitive to that. There's a gentle palpation of the pelvis. And if you feel that it's not firm, you stop doing that. You can actually hurt somebody if a small child, if you really shake their pelvis, you can tear a iliac artery. Yeah.
Se non ce l'hai, l'importante è che se il bacino è stabile, si perde. Se il bacino è stabile, sì, non lo vedi neanche non vedi niente, e questi ti saltano a testa. Quindi ma solo dei pazienti che sono stabili.
The thing is with the pelvis too, I mean, the places that you can gather blood is chest. You'll see that on x-ray. Abdomen, you're going to see that with your ultrasound quite well. Pelvis, harder to see that. So the pelvic CT is good. Femur, you'll usually see that because it's really getting swollen there, but you can lose a lot of blood in your femur. And then for pediatrics, in the head, because the bones can swell and stuff. If I get a little bleeding, I'll have symptoms. But a child can have quite a bit of, especially intraventricular bleeding, blood into their ventricles. So that's where we can sort of hide blood. And then remember the scalp laceration. It's very vascular. It bleeds a lot. So, I mean, you all have seen that 6-year-old child who has a ball hit him and, he has a lot of blood. But a little baby with a scalp laceration is a big deal. You have to control it. So then for the next step, you've gone top to bottom, you have everything. I didn't mention the labs that we check because that's a little bit changing also. Of course, you'll check the blood count for anemia, but should you check coagulation? Probably. Should you check the liver transaminases? Usually we do. But the routine labs are changing, I think. How, amylase, I don't know. So it depends on your institution, where you're working. But once we've decided what we have, now we probably know all the injuries, then we have to prioritize which has to be fixed first for the patient's life. And that's a discussion. Usually the head is the most important. So if there's a neurosurgical problem, this is going to be it. If there's evidence of ongoing bleeding, maybe abdominal surgery. But honestly, usually the common injury is liver and spleen injury. And usually we don't go to the operating room for that. Even if the patient is unstable, at least in the US, if you have low blood pressure and anemia, and we know you have a splenic injury, we still don't open your belly. We give you a transfusion, we stabilize you, and we wait. And if it bleeds some more, sometimes we'll transfuse you again and stabilize you again. We still don't open the abdomen. It used to be a lot more abdominal surgery. We would just open the abdomen and the surgeon would look at the spleen and sometimes clamp it and take the spleen out. We don't do that now. We want to save the spleen and we use interventional radiology. Sometimes they go in the femoral artery and they embolize if need be. But the patients in the ICU, we transfuse them, keep them stable. Also in Italy, yeah. So we don't, so that's really more details about trauma management, and that's not the source of this lecture, is more on initial assessment and initial treatment. But just for your interest, we don't do so much abdominal surgery. Finally, all these other things you can get, you can do angiography, you can do chest, you can do all kinds of CAT scans, CT scans. The main point in here is the C of ABC does not stand for CAT scan. Don't go to the CT scanner until you're stable. Because like we were talking about, it's the coldest, loneliest place in the hospital, and people go to the CT scanner and they get unstable. And sometimes they have cardiac arrest in the CT scanner. So just, the patient has to be stable first. Okay. Probably, we want to have time to do the demonstration here. And she told us, so we only have, we only have 17 minutes or something. So all I would say about transport specifically is you just have to know what your resources are. And transport should be protocolized as much as possible and have the communication open so the transport team can easily talk to the hospital. So these were the references I thought were helpful. This Royal Children's Hospital, I didn't know about it. I was actually quite impressed with this website. They have a nice resource. Basically, everything I told you is there. It's a good resource. And then I made a little tiny URL for you guys for about the physiology and of children and anatomy. It's kind of cool. And the workup, again, basically what I've been telling you, you can find it all here. So, and then last, if you have questions, please feel free to email me. I'm happy to have a discussion with you or tell you anything. And yeah, so now we're going to do some demonstration of the practical equipment. So yeah, come on up here.
Allora, abbiamo fatto la parte di regolarizzare questi pazienti, no? Quindi dobbiamo sapere come viene liberato il problema di prezzo. Siete sicuro che posso avvicinare? Ok.
Mhm. Just like we did up there, the airway looks good. And I don't see anything there. Trachea is midline.
Okay.
Looking at that, we'll put the oxygen on the patient. Okay, here we go. And you've seen this already, but we'll feel under, it feels good there. We'll get this gentle, stop right there, over the top. Nice Velcro, good,
Okay.
nice. B, the usual, like we talked about before, first observation, looks good. Palpation, top to bottom, auscultation, yes or no, left, right, X, okay? And then circulation, B is okay.
Ok, la cosa fondamentale, non ancora, che era di ricordare il fatto, che come era questo paziente stabile, eccetera, e nel fatto si deve fare una cosa fondamentale che è la di parte di oggi le emorragie che devono essere bloccate immediatamente. Se non riesco con le compressioni, ok, con le procedure, con il troppo imponente, eccetera, devo direttamente. Ok, si mette subito al di sopra della ferita, quindi se la ferita è qui va messo qui, se la ferita è qui va messo qui, si va a salire. Se non basta, ne mettiamo un secondo direttamente. Ok? Quindi vado qui, me lo metto qua per comodità. Ok? Chiudo, comincio a stringere, stringo fino a quando non si ferma l'emorragia.
It's fine, no, it's fine.
E scrivo l'orario. Non si leva più, okay? Perché appena lo allentiamo riparte l'emorragia. D'altronde ho circa 6 ore di ischemia di arto, non solo, più ischemia con l'arto, più quando lo riapro mi fa quello che si chiama sindrome da rivascolarizzazione. Questo sangue è freddo, pieno di potassio, pieno di calcio, pieno di carotenoidi, mioglobina, tutte cose che rischiano di farmi un respirativo quanto meno. Ok? Lo levi direttamente in sala operatoria, l'importante è che l'orario è stato messo. Vale per tutti gli atti, ok, superiori e inferiori, dove non posso arrivare con questo qui, o altri sistemi, ok? O le compact close, sono le carte particolari sostanze che mi aiutano la popolazione e faccio quello che si chiama il gap control della ferita, quindi studiare la ferita. Quando non posso quindi sicurezza, profilo let's have someone else up. Remember like that. Why don't you? Yeah, adesso passo il G. Sempre assolutamente.